I'd like to personally thank all of you for attending our event today. In our current state of affairs, I'm certain the last thing you thought you'd be doing is attending another Zoom thing. So thank you again, and hopefully it'll be worth your time. I'm going to be talking about concomitant atrial fibrillation surgery. All of you attending today either have atrial fibrillation or know someone who has the diagnosis of atrial fibrillation. But before we start, I want you to imagine you're 25. 25. Remember, you could do whatever you want. Stay up all night, dancing, eating, drinking, other things. Never once did you think about your heart. And that's because atrial fibrillation is associated with aging. It's extremely rare to be diagnosed with atrial fibrillation when you're young. Now, I can't promise that you'll feel like you're 25 again, but I can promise you that if you achieve sinus rhythm, you will feel better. And that's why we're here today. So back to concomitant atrial fibrillation surgery, and what does that mean? If you're having open heart surgery, like on the left, you have atrial fibrillation, then for all intents and purposes, you should be getting the Cox-Maze operation to correct your atrial fibrillation. So on the left, this is your heart on the heart and lung machine, which is perhaps the greatest medical machine ever created. So what is the heart and lung machine, or cardiopulmonary bypass? Basically, it allows the heart surgeon to fix the heart by removing deoxygenated blood from your body, putting it into a reservoir and pumping it through an artificial lung to remove carbon dioxide and adding oxygen, and then returning the oxygenated blood back to the body. Or, as I like to say, taking blue blood and making it red. So now, what is the Cox-Maze operation? It was an operation devised by Dr. Jimmy Cox to correct atrial fibrillation. It really is a rarity in surgery in that it was a disease that was studied in the lab on basis of known mechanisms of atrial fibrillation, and then tested in dogs, and ultimately determined the feasibility of an operation and a surgical cure for atrial fibrillation in humans. And he did this in a series of papers that were published sequentially, and eventually leading to the Cox-Maze operation. He then applied this operation and followed those patients to determine how successful it was. Basically, it had a greater than 90% success rate and extremely low risk of stroke long-term. Despite these excellent results, there weren't a lot of patients who had lone atrial fibrillation who wanted to sign up to get their chest cracked, as my friendly cardiologists like to say. But Dr. Cox had the foresight to apply the Maze operation to patients that even had open heart surgery for other problems as well as atrial fibrillation. He noted that the Cox-Maze procedure had an equal operative risk and long-term efficacy rate in patients undergoing both lone operations as well as concomitant. So basically, the Cox-Maze procedure is making incisions and ablation lines to redirect and block aberrant electrical impulses and allowing for your natural conduction system to go down a defined pathway and restoring sinus rhythm. As I like to say, it's like a cornfield maze where you have to find the right path to get out. So if you have other surgically correctable heart problems and you're undergoing mitral valve repair, coronary bypass grafting, aortic valve surgery, double valve surgery, and you have atrial fibrillation, then this is your opportunity and your surgeon's opportunity to cure you of your atrial fibrillation. And again, if you have to have mitigating circumstances or you have to have some risk factor profile that prohibits the Maze operation from being performed, the answer from the surgeon can't be, it doesn't work. I don't believe the data. You're not a good candidate. If that's the answer, then the next appropriate question from you is, why? Why doesn't it work? Why don't you believe the data? Why am I not a good candidate? And if you're not satisfied with the answer or the explanation, then that's your opportunity and excuse to seek a second opinion. If you think of your heart as having 4 chambers, 2 upper, 2 lower, right and left, the Cox-Maze operation involves incisions and ablation lines in the upper chambers. Here is a depiction of the cuts and ablation lines in the right atrium. Here's a picture of the lesion set in the left atrium. You can see that if you're having your mitral valve repaired, which is in the right upper corner, it doesn't add much to the operation to correct your atrial fibrillation. So what does the literature say? In 2014, all of the major heart societies came out with a revised consensus guideline statement for the management of patients with atrial fibrillation. This is a busy slide, but just like a traffic signal, green is go, red is stop. Where you want to be in regard to recommendations is in the upper left-hand corner. Class 1, level A, where there's a definite benefit of doing something backed by multiple clinical trials or meta-analyses. So in 2014, there were only class 2 level A recommendations, yellow, caution, for concomitant atrial fibrillation surgery. In 2016, the European Society of Cardiology, in collaboration with the European Association of Cardiothoracic Surgeons, published their guideline paper. And patients having heart surgery and symptoms related to atrial fibrillation, again, class 2, level A recommendation, yellow, caution. Remember, this is more than 25 years after Dr. Cox published his initial results. In 2017, the Society of Thoracic Surgeons, which is the largest international professional society for heart surgeons, came out with our clinical practice guidelines for the surgical treatment of atrial fibrillation. And what does it say? Surgical ablation is recommended for concomitant mitral valve operations, class 1, level A. Remember, upper left corner. Also, surgical ablation is recommended for concomitant aortic valve operations, coronary artery bypass grafting, aortic valve plus coronary artery bypass grafting, class 1, level B, almost in the upper left-hand corner. Additionally, surgical ablation is reasonable to exclude the left atrial appendage to reduce the long-term risk of stroke. They also recommended in the treatment of atrial fibrillation a multidisciplinary heart team, similar to everyone today, which could be useful and beneficial for long-term outcomes. So let's put it all together. If you're a patient with atrial fibrillation and you're undergoing heart surgery and you have symptoms related to atrial fibrillation, you should have a concomitant Cox-Maze operation. The take-home message is this. The Cox-Maze operation for the treatment of atrial fibrillation has gone from lab to animals to patients and has over 30 years of clinical experience. It has gone from investigational to reasonable and now class 1 level A recommendations to be performed concomitantly if you're having heart surgery. So if you're having heart surgery and you have atrial fibrillation, the question is not, why should I get concomitant Maze operation? The question is, why not?